So my name is Vadim,
My name is Paul.
and we are here with Mimi Firmer. We are doing a project about Asthma Educator. So please tell us who you are and what made you choose respiratory therapy to begin with, and your story background.
Okay. So obviously, I'm Mimi Firmer. I always worked in the hospital environment and knew that I wanted to work with patients and help people. It just took me a while to figure out in what capacity. I started out just kind of doing varying jobs in the hospital. I was a dietary aide and a pharmacy clerk and then a surgery scheduler. And I started thinking about going back to school, and an opportunity was presented to me for going into a respiratory program and also becoming an equipment tech at the same time. So I was able to do, really get into it right from the get-go. So I jumped at the opportunity, and here I am 21 years later, still working in the field of respiratory, and both at the bedside and educating. So.
Well, I'm wondering, what are some facilities and places that you have worked at?
So I've worked at Kaiser Morris Avenue. I worked a little bit at Kaiser South Sacramento, helping with some respiratory stuff, and then also Kaiser Roseville. And then now I currently work for Sutter Roseville.
Kaiser all over Sacramento.
Yeah.
I have a next question. Many practicing therapists and students who are learning to become RTs do not know about other branches. So we know that you're an asthma educator. Can you briefly tell us about other branches and what made you go to asthma educator and what that is even about?
So as far as asthma educator, I found the certification, and at the time, I had a nurse practitioner friend that worked at Kaiser in the Bay Area and actually ran an asthma clinic. And she told me about, the asthma educator. And I was hoping that at, some point there would be opportunity within Kaiser to utilize it, but that didn't really come to fruition in like a clinic spot. But I used the tools that I learned from, studying the asthma educator just information, and then taking that test. I utilize that in my day-to-day practice, whether I'm at the bedside or maybe discharging when patients get ready to discharge home, being able to help them, with their medications and instructing them on how to use things correctly. And also it helps in when you're making recommendations to the physicians to help, support the patients when they're being sent home. Other areas that you can go into as a respiratory therapist outside of working in the hospital are pulmonary rehabs, case management positions, obviously asthma education. You can work in multidisciplinary clinics, such as like a cystic fibrosis clinic, which I also had experience working in. Sleep labs. Those are all varying avenues you have as a respiratory therapist. Yeah, we all want to sleep. So, but we want good sleep. And then home health. Don't forget about home health, so.
Awesome. All right. Well, I know you kind of touched up on it a little bit, but I wanted to ask a little more in detail. How much like schooling or like what sort of certification and credibility did you have to go through specifically for being an asthma educator?
So for the initial credentialing, you had to be practicing for a certain amount of years at a certain amount of hours each week. I know those have changed because I've been credentialed for a while. But I want to say, I think it was at least 4 or 5 years in the field and at least 20 hours a week, of practicing, working as an RT. And then I had to pass a pretty rigorous exam. It's big. Lots of questions, about as big as your guys' written exam that you're facing yourselves. And then every 5 years, I have to recertify, and I have to do so many CEUs in asthma education, per recredentialing cycle to meet their qualifications.
So how does how does it go? So let's pretend you're the educator and I'm the patient. So how does like a one-on-one sit down with you? How does it happen?
So when I would, talk with patients about asthma, and we were trying to get to the bottom of things as far as, why they would continue to have exacerbations. Generally, there's a asthma action plan that patients are placed on, and that's something that you would do, through the clinic that you're working in. And those plans are usually developed by the physicians and the asthma educator or the RTs that you are working with. But generally, you're trying to find known triggers. You want to see what their medication use history is. You want to see if they're using their peak flow meters to manage their symptoms, or not actually manage symptoms, but to just monitor their asthma so that they can see if it worsens before they actually start to feel it worsening. And then in those plans, you discuss what your steps are if your peak flows drop, as far as what meds you're going to take, how much and when, and if that's not responding, what you're going to do next. All the way, they step it out all the way up to when you need to be calling your physician and seeking care.
What's like an average like age group you would say is like the age group of your patients mostly, or do they vary?
They vary greatly, from kids all the way to senior citizens. The worst ones, though, the hardest ones to get to stay compliant with their medicine regimens are teenagers, because they don't want to listen to an adult. They think they're invincible, and they also their bodies tend to, they compensate a lot longer for things. As the older you get, the less intolerant you get to, having to work so hard for too long. But yeah, age ranges from babies all the way through senior citizens.
Awesome. Okay, well, I'm just wondering, are there like early signs to look for in a patient that like may indicate that an asthma attack is coming on? Like, is there like general signs, or is it like each person's absolutely different and you can't just like, pick and choose one to look for?
One of the biggest signs is looking at their peak flows and finding out what their normal range should be. And if they're not within that range, or they see a sudden drop, that can actually show you that there's something coming before they even have any symptoms. So that's one of your best tools in managing asthma is, utilizing that peak flow meter. Now, if they don't have one, things you need to look at are their usage of their inhalers. So you really need to probe into their medication use. Ask them, how many times a day are you using your albuterol? Are you using it during the day? Are you using it more at night? Are you noticing that you're, coughing more, or are you noticing that you're starting to, work more with your breathing, depending on the things that they're doing? Sometimes they don't realize it until you really have them stop and think about what it is that they're using. Or if they're calling in for a refill on a 200 dose MDI 1 week after you've given it to them, we've got a problem. So things like that.
How often do you get called up to educate patients? Like, how often is this position open, or like,
So as a staff therapist, you're doing that a lot, probably every day, going over something with the patients prior to them going home when you're working in the inpatient setting. But as an educator where I'm at now, I am more so doing that with the staff and how we'll, disseminate that information out to the patients, and working on programs to help reduce them being readmitted to the hospital per se.
That was my next question. Like, how often do you get back the same patients coming in and you're like re-educating them, like consistently, like, hey, welcome back again?
Yeah, so that's a great question. So I know in the Kaiser system and in the Sutter system, they have identifiers in their chart that show their readmissions and how long it's been since they were discharged from the hospital. And they make recommendations to get them into, say, the pulmonary rehab programs, or they get them in with the chronic conditions management departments, where they can be assigned a case manager that follows them a lot more closely to help keep them from coming back into the hospital.
Okay. So with that being the case, I'm kind of curious, what are like some difficulties that you come across as an asthma educator? Like I understand like teens is probably the biggest, and people who are not listening, but like, is there other like maybe things that people don't commonly think of that are issues for asthma educators, or?
Sure, just educating people in general. There can be language barriers, there can be money barriers because they can't afford the medications that are being prescribed to them. Sometimes they're maybe embarrassed to say, I can't afford the Advair, but we can find them less expensive alternatives to help with making sure that they stay on that kind of a treatment regimen, and then other things are they just don't like to use their aero chamber or they didn't know they should use it with their inhalers. There's those kinds of things. And then they run out of stuff and they can't get a hold of, say, their doctor, or they can't get a hold of a refill in a timely fashion. And before you know it, they're in a full-blown exacerbation.
Okay, so this is a question that I kind of thought up specific, just as I was like trying to figure out what we could ask you. Do nighttime symptoms hold like a different meaning compared to daytime symptoms, and like would it require like a modification to the asthma plan?
Yeah, some patients don't realize they're having symptoms until they lay flat. And so, some patients can develop, orthopnea, or not develop it, but you'll notice it. And they'll complain that they're having trouble at night sleeping because they're coughing, or they're having to prop themselves up with pillows to sleep better. So yeah, there's different, symptoms that you look for, and questions that you can ask to kind of pull that out of them, because they're not really great at telling you exactly everything.
One last question. So we talked about what it is, everything, how you need to get certified. What is the pay? Like, do you have like an extra bonus for that, or is this just like a requirement so you can do more things with it?
Actually, there's no increase in
Incentive?
pay or anything like that. It was a professional choice for me to obtain that certification because it lends some additional credibility for depending on the facility that you're working at, and the patients as well. When they see that you specialize in something, it just gives you the knowledge base to be able to handle and field the questions and the problems that they're dealing with. So, but yes, there's no, pay increase for it within the realms that I've been.
Perfect. Awesome. One last thing. Advice for new RTs, and then we're gonna let you go. What is the number one advice you would give every new grad? Because we have 5 weeks left.
As far as like, applying for jobs, or just what to do once you're out there?
Once we're out there, once we're out in 5 weeks.
Once you're out in 5 weeks, hit the ground running. And when you get into whatever facility that you're working in, you take every opportunity to learn every single thing that facility is doing. If they have a NICU, you ask how fast you can get trained in the NICU. If they're doing nitric oxide, if they're doing the VDR ventilator, if they're doing bronchoscopies, if they do pulmonary function testing, go and get experience and exposure to every area that you can, and get every certification that you can get your hands on. So your CPFT, your RPFT, get your NPS, get experience in doing the different kinds of bronchoscopies. If you can find a center that does ECMO, fantastic. That's another area that you might branch into down the road. So good stuff.
Thank you, Mimi. Thank you for your time.
Thank you for everything. Thank you for coming out to have an interview with us. We really appreciate it.
Thank you so much.
All right. Good luck, guys.